Um, Good afternoon. This is Ahmed Youssef, one of the ENT head and neck surgeons. Um, Today, we're going to touch base about an important topic for ENT and for our colleagues in anesthesia as well, anesthetics, emergency doctors, and also for ENT trainees as well as other non-head and neck ENT consultants. Um, that's regarding airway management in adults. I will try to, in a 30 to 40 minute, to get a brief about how to safely manage an airway from the different point of view. It's an MDT, as you know, multidisciplinary team management of an emergency airway. So patient usually presented in the A&E first or an emergency first and seen by an emergency or an ICU doctor. Then it will be called like as an anesthetist or as an ENT trainee or a consultant to observe the patient. Meanwhile, there will be like few minutes downside the road, and you have to do something to buy some time before already starting the real management of the airway. So to start my presentation, okay, here you go. So we're talking about the steps of an adult airway management in terms of the steps or the stepwise and the algorithmic or stepwise thinking, how to safely manage an airway, and then we'll talk about some scenarios as well. First of all, when the patient is presented with an airway obstruction, we call it presented as an adult with a stridor. It's a noisy breathing. It's a high pitched sound, usually being presented in the emergency for someone 18-year-old or older to call it as an adult airway. Whenever you see it, if you able to get some words from the patient or from whoever joining as a partner or wife or whatever, or a friend, to talk with him or with whoever joining him briefly about the history, onset, course progression, in other symptoms, like if the patient can give you some history about a change in voice, like red flag symptoms in the head and neck, difficulty in swallowing, weight loss, neck lumps, is a smoker, alcohol drinking. That's all useful information if you can get it. Meanwhile, we're taking a history from the patient, you're managing the airway simultaneously and looking for an airway signs and assessing the patient and managing. Assessment here for looking for signs of an airway efficacy, like the patient is really struggling for breathing. He has an effort to overcome the obstruction. And this is a signs of airway efficacy or distress, which is basically like what someone is fighting for breathing. In addition to the stridor, you will find have a nasal flaring, intercostal, subcostal retractions, and some tracheal tug, which is elevation of the trachea, and you can feel it in the neck. Signs of efficiency, it's related to the oxygen saturation. In other units, you can go ahead and do what is called an anterior blood gases. We don't recommend it because this is again something invasive and can distress the patient more. So if you can go ahead and do some oxygen saturation with a pulse oximeter, that can be a good option. And we know that the oxygen saturation will start to drop later on the course of a severe airway obstruction. It wouldn't drop straight away because this patient is still ventilatable. But still, you have to get an idea about the oxygen saturation. While you're doing that, you can start by some basic measures as well, which is putting the patient on a mask of oxygen and use the nebulized adrenaline in terms of 1 centimeter of 1/1,000 adrenaline in or a 2 in addition to a 2 cc or a 2 ml of saline as a nebulizer setting that can help the airway of the patient to be better. Also, you can insert a cannula, an IV cannula. It's less invasive than doing an ABG, which is arterial blood gases. And putting a cannula, they can start by giving the patient a dexamethasone And you can start with a 6.6, or some in other parts of the world, it's an 8 milligram of a dexamethasone to start with, or they can start sometimes with a hydrocortisone, depending on the hospital and policy and the available resources in your department and your hospital. While you're doing that, you can buy some time, improve the less congested airway, improves the breathing a little bit. You will go ahead and examine the oral cavity and oropharynx, and also go ahead to examine the airway further, usually by flexible nasal endoscopy, rather than to distress the patient more by doing a rigid endoscopy of the nose and nasopharynx and the larynx by 70 or a 90-degree. Sometimes it's the only available tool in some poorly resourced areas. However, you can still do it if the patient is a little bit more stable. But ideally speaking, in most of the hospital nowadays, if you can have a flexible nasal endoscopy, that will be ideal to examine the airway in some of the unstable patients. In terms of if they still is distressed, you still can go ahead and examine the airway with a flexible nasal endoscopy and use, sometimes you can use a topical Otrivin or a topical xylometazoline or a cofenilocaine in other, depending on where you are working in UK or in Egypt or wherever, any part of the world in the US. So sometimes you can go ahead and do that without putting anything, not to distress the patient anymore. And you examine the neck as well as a part of your assessment, just in case if there is any swelling or any nodes or any thyroid lump, you can feel it to get an idea about the cause of the obstruction. And after that, you have like the first 5 to 6 minutes or a first 5 to 10 minutes. You buy some time by getting some measures like an oxygen, nebulized adrenaline, and that's really important. And getting a history and examine the patient to have a look and see how the patient will be presented or improved after that. If the patient shows signs of improvement, so you can admit the patient safely and putting it in a high dependency unit or an ICU or a ward, an ET board, experience it with an airway deterioration, and you start to investigate further. If you have like a mass, then you can think about doing a microlaryngoscopy and biopsy or a DLM biopsy and getting a CT scan as a beginning. Or if there is an external lump, you can still have a CT scan of the neck and investigate further depending on what is the reason of obstruction. However, if the patient didn't show any signs of stability, then we go a step higher. That's a point when you need to talk to your experienced anesthetist or any good anesthetist in the hospital. If you have an airway anesthetist with you, that would be great. If not, try to talk to a senior person who is aware about putting an NDT plan with you. Sometimes the ITU or ICU person can help as well with that if you don't have that anesthetist on board. And the options here will start with the simple non-invasive measures, which is again to buy some time if the patient really distressed, and or a definitive airway management. We're talking about a definitive airway, which is something, anything, according to the literature, bypassing the vocal cord, like an endotracheal tube or a front of neck approach below the vocal cord to get an secure airway. So all what we were talking about is an options of non-invasive or even many invasive non-secured airway. It's like a temporary airway until you secure the air, until you get a definitive airway by intubation or a front of neck approach. What is the options we have here? And usually this will be managed in a theater setting or an OR setting or an ITU setting rather than in the emergency. So whenever you see patient not improving, you talk to your anesthetist and ITU and put a plan where to manage the patient and how you will manage it. Options here for non-invasive airway will be we talked about the definitive airway. We need a good content airway anesthetist is crucial. And he looking for a ventilation. That's a way that you're thinking about it. That's a plan how you will ventilate the patient and how you anesthetize it. That's really important, and we will talk about it in a minute. Temporarily, we have the nasopharyngeal airway or an oral airway, and you have to learn how to put it. The nasopharyngeal airway, you can measure the distance between the nasal vestibule and the angle of the mandible to get an idea about to up to the tragus to get a point to get an idea about the length of the nasopharyngeal airway you can use for an oral airway. It's between the angle of the mouth and the angle of the mandible. So you can get an idea about the length of the oral airway. Usually, if the patient really distressed and is starting to show signs of desaturation or started to get some sedation with the anesthetist, he will start with that, with an oral airway, and he put it on upside down, and then he reverse it. So he put it like the convex thing will be on the tongue, and then he will rotate it 90 degree until or 180 degree until it's been facing the convex, facing the palate. Then that's all a temporary measure. We have the laryngeal mask airway. That's really useful, especially in airway stenosis, because you can get a bit of oxygen through a tiny stenotic component in the airway, either subglottic or laryngotracheal stenosis. So you can still rely on that to get some time before dilating the stenosis or even doing a trach. That will happen using this laryngeal mask airway. It's a supraglottic airway. It's sitting on the epiglottis. It is not a definitive airway because it's not bypassing the vocal cord. It's not useful in cases of an edema of the airway or distortion because it wouldn't go, the oxygen through it or the ventilation through it didn't go the right way. Still, some of the air will go to the hypopharynx and the esophagus, but still it's a good way to non-invasive way or a minimally invasive way to manage the airway temporarily until that you can put an ET tube. Options for intubation, that would be the next step, and the intubation should be done in a theater or an ITU environment. And here is a patient will need some sedation to start to be able to intubate. And that's a crucial point, and that's a conversation with the anesthetist or an ITU person. We don't like to have any paralysis. Some people will go for a short-acting muscle paralysis, but that's something that needs to be discussed with the anesthetist or an ITU to facilitate intubation, especially if the airway is patent, you can get it, is it not very well, it's not so distorted, so you can get an airway easier. Or if it's really distorted and you are not guaranteed, so with a flexible scope, that you can get a good airway, so it's better not to do any muscle paralysis. Myself, when I have a conversation with the anesthetist, I usually push him back not to do any muscle paralysis. Options here for sedation, either a ketamine, which is something which have a dissociative anesthesia. Our anesthetic colleagues know that it doesn't have a full sedation. It's a dissociation and will help with any measures or any maneuvers you do it. And options are a propofol, but you have to titrate the dose well with the anesthetist. The anesthetist will titrate the dose well to get some sedation rather than to allow a respiratory depression. And then you are in an emergency situation. Sevoflurane or a gas induction or inhalational anesthetic is another good option, and it's a preferred option actually in kids when you manage the air and when we manage the airway. So how do we insert an endotracheal tube? We have options of a different sizes of plates of laryngoscope, the Macintosh laryngoscope, as you can see in the pictures. There are like other designs of laryngoscope, handheld laryngoscope. Our anesthetic colleagues are very happy to use it, like a McCoy, or they can use angled or a long blade or a curved blade. That's really useful. It can help. And that's a first trial with the anesthetist. You don't anticipate multiple trials. You go to one or two by your anesthetist, and he has to be prepared with what he needs in terms of the anesthetic plate or laryngoscope plate and the shape of the plate he will use, and depending on the options as well. Myself, I prefer to use this, which is present on most of the units nowadays, which is a CMAC or as a video laryngoscope or a glidoscope. Is the same idea. All of them allow you to see what's going on when you putting your laryngoscope on the tongue or the tongue base. That's useful sometimes to deal with a distorted airway, useful very well in limited mouth opening, and patient will have a limited trismus or a limited extension that can give you a better view because it's, as you can see, it's a little bit curved and it can show you what's going on, especially with the video laryngoscopy or lidoscope rather than even the CMAC itself, but depending on, again, availability. And that's actually very useful in cases of patients that have a short or obese neck, patients that have some distortion of the airway, some limited mouth opening, and all of this can be very useful tool to get a better airway because you see what's going on rather than to insert the tube and depending on your own visualization. One of the good tips to insert an ET tube, and we use it usually in children, is to glide a tube or reload a tube on a scope, and that's going to be very useful as well. Whenever you dilate an airway, especially in airway stenosis, you want to intubate. You can use a small ET tube railed on a 0 degree, preferably, rather than a 30-degree scope. It's long enough to, which is we can use it in urology as a longer one, or if you have a definite airway one to examine the airway, to railroad the tube on top, and then you can see what's going on if you don't have a video laryngoscope. That's all options. So video laryngoscope is an option. Okay, and the other option is you can use your railroad ET tube on a 0 degree scope or a 30-degree scope to get an airway. What else we can use? The anesthetist can use to get a good airway, especially if the airway is distorted, edematous, or have a mass, is use a bougie. Bougie is very useful tool because can extend the airway. And again, it's something equivalent to when you use a railroad tube on a Hopkins rod. It's a bougie. It's like a guide. You can do it with video laryngoscopy or with your anesthetic laryngoscope, and through it you can railroad the tube on top of it, and then you can secure the airway such way. Some other options in other units, depending on the availability, is the weak fiber optic laryngoscopy, and that's a preferred option in non-distorted airway, which means that the airway is compromised by having a teresmus or having a difficult neck extension, so you cannot position the patient well, kyphotic patient. All of this suspected airway the difficulty. All this awake fiber optic intubation using the same flexible laryngoscopy, but it will be a bronchoscopy because it can be long enough, and depends on the skills and the experience of your anesthetist if it's comfortable to use a video laryngoscopy or a flexible scope, or yourself that you can use, you can intubate the patient with either way, or using the railroad ET tube on the Hopkins rod. This is all options. Awake fiber optic intubation is the same. You topically anesthetize the nose and the oral cavity, and also you will, the anesthetist will guide the flexiscope from the nose until he's going between the two vocal cords, and such way he can, and it's long enough, he's already, the AT tube will be railroad on top of it, and it's long enough so the tip will go and part of the flexiscope will go enough into the airway, and then you can push the tube down and make sure it is in by pushing the scope in and out, so you can, the flexiscope, so you can see out to get the tube in, and in to check that it is the tube in trachea, so you can make sure that it's a secured airway then. That's a flexible, and this is an awake fiber optic intubation. This is very preferable in cases of neck abscess, in cases of deep neck infection, neck hematomas, because this airway is compressed and there might be a teresmus or a distorted airway, not from an external compression. Awake fiber optic intubation is good because the patient is maintaining ventilation using his drive. However, distorted airway, it could be an option, but I prefer in distorted airway with a mass or a stenosis to use a video laryngoscopy or use an ET tube railed on a Hopkins rod, or we can use what is called a laryngoscope, the metal laryngoscope. That's another option if you don't have the video laryngoscope. And to be able to see the vocal cord well, we have two options of the laryngoscope, as our ET colleagues know. We have the Lindholm one or a Concessor one. That's not ideal. I prefer the anterior commissure one because it's slender-like and can get all the way down to your vocal cord. And it's long enough and small. It just allows you to place a bougie and on top of you. And once you get the bougie in, you take the scope out and you put your ET tube on the bougie. And that's another nice design. One of my mentors have already invented the same like an anterior commissure scope. It's called the view scope, the same, but it's disposable and have the lights built in. So you can still put it, whatever the airway is. And we tried in many institutions and many occasions and worked very well, whatever the airway problem is because it's easy. You insert it on top of the tongue, on top of the tongue, and go all the way by its own to the view, to the larynx, whatever the larynx is distorted or not. And the good thing about it is not very traumatizing, and the light is away, so you still will not be distorted. The light cable, like the normal laryngoscope, wouldn't be cloudy with any blood or anything, and you put a bougie in and then you take it out and put the tube in. So what other options are? If you really struggle to get an airway using an ET tube, and that's a priority, and that's a trial, you give it to your anesthetist once or twice, and you should be working closely with him or her, and the third trial should be yours. And if it's failed, then no more options because the patient at that time has like at least three trials, and then the airway will be more edematous and more distressed, and the patient will start losing a ventilation drive. At that time, you don't have many options. You have to get an airway quickly, and we have here two options, either using a front of neck access. And the options here are a temporary measure with a cricothyroidotomy or actually an emergency tracheostomy. Okay. And both ways I know that there are like different ways of doing it, transverse incision. So for a cricothyroidotomy, whenever we suspecting an airway, I would go for this method rather than a tracheostomy. I know our ENT colleagues are really familiar with the tracheostomy, but they can try to do that in their patients. And you will find that it's very effective and very quick, much quicker than the tracheostomy, even if I know that we good people, especially head and neck surgeons, are able to do a tracheostomy in a quick way, like few minutes. However, cricothyroidotomy isn't ideal because it can take inexperienced hand or some even in unexperienced hand, like less than a 5 minute. You inject some local, whatever you're doing at awake tracheostomy, lower down between the cricoid and the suprasternal, or if you're doing a cricothyroidotomy, which I encourage you guys to do it, is to inject some local in after you marking your thyroid cartilage and cricoid cartilage, like here, and you inject some local. Personally speaking, and the American way of doing it, is doing a vertical incision. And why the vertical incision? It's even if it's not like it's very not good in terms of the healing, it's quicker. And the vertical incision can get you all the way down, even between the strap muscles, straight away to your cricothyroid membrane. While the transverse incision, you will still need to retract it a little bit up and down and try to get into the membrane, maybe wider, easier, but it's not easier. I would say we'll have some bleeding more. So the vertical incision is quick. You get some local and you put your scalpel vertically between the cricoid and the thyroid until you feel like the membrane or the bone, and then make you rotate your scalpel like a 90-degree so you can get exactly into the thyroid membrane and cut it. You don't need to use any mosquitoes. You don't use anything. The mosquito, once you get through it, you can use a mosquito or a dilator, and you can put a bougie and then, or a small ET tube, and you curve it down. Okay, some people will use a needle cricothyroidotomy. I don't prefer it. It could be. The anesthetic colleagues will be preferable this way, but that's your job, ENT guys, and you have an ENT person with you, especially if any ENT trainee should do it, or an ENT resident or an ENT consultant should be able to do this cricothyroidotomy. Vertical, go all the way down, and then transverse, you get through a membrane and put something in as a dilator or anything, or a bougie, and then you put the 80 tube, a small one like size 5, should be enough before you're going for your tracheostomy. Tracheostomy wise, we have an open surgical tracheostomy. I know there are like two ways of doing it. Exactly, we marking the cricoid and the suprasternal notch and go between the halfway through it with some neck extension if we can in adults, if you can. The way to do it, either to do it a transverse again, and I shifted my practice now to be a vertical for the same reason. I get some local in, I put a vertical incision in the midline, no bleeding, go all the way, cutting no platysma in the midline. We go straight away to between the strap muscles, dividing them with a blade or with a bipolar or with a scissor, and then you are actually on the isthmus. I usually to divide the isthmus with a bipolar. I will never keep it. The transverse incision will allow you to dissect above it or below it. I hate that. I'm dividing my isthmus with a bipolar or a coherent, whatever, quicker with a bipolar or a monopolar and sort out the bleeding later. Remember, if we are doing that, it's an emergency treatment situation. We don't care much about the bleed, but try to help yourself. Vertical incision and go straight away in between the strap muscles to the isthmus. The only thing that will bleed in that case will be the isthmus. You can sort it out this with a monopolar or a bipolar. After the isthmus, if it's a little bit oozy, you are on the trachea. And you can open the trachea. I usually do it between the rings. I open between the trachea rings transversely and get the lower flap, suture it if I can, if I have some time. I dilate the opening after doing a transverse incision by putting a scissor or a dilator to open the trachea a little bit wider. And then I will try to fix the lower flap with a vicryl to the subcutaneous tissue. And such way, whenever you get the tube out, the trachea will heal up on itself. You don't need to cut any stitches. You need to do any flaps. Other ways of doing it is the Bjork flap, like we will talk. We'll get this an idea how to do it. Doing the incision vertically in the subcutaneous tissue and get like a cat's paw or sim retractor in between. And still, as you can see, I don't find any bleed so far. I didn't use any suction or anything. The way down. And I'm dissecting it all the way down. And this is a lead patient in an ITU. It's not like a cadaver. So I'm sorry, I'm taking in a different language or whoever hearing it. So I'm doing a retraction of the strap muscles right now. And then I'm feeling my trachea and isthmus. And probably I will use a bipolar just to divide the isthmus here. Didn't find any bleeding. It was a clean one, as you can see. Just to use a suction in the top of the trachea, and then we are now opening the trachea. You will find it a little bit. You will find the ET tubes between the rings, and I widen it more and putting some stitches in the lower flap here to the subcutaneous tissue to keep it open. Okay. Yes. And other options of doing a tracheostomy, some people will take some rings, 1 or 2 rings. I don't like that because it will end up with a scar tissue. Some people will do a Bjork flap, a base down flap, and suture the upper end of the tracheal flap to the subcutaneous, or actually, ideally, to the skin, and then they will cut the stitches out when the patient is weaned. There is a risk this is not being cutting out, especially whenever you don't see the patient anymore, or it's an ITU patient or whatever. It's managed by other specialties, so it can end up with a tracheocutaneous fistula. This way, what I'm doing is you get a good track, and usually the change will be in 3 days. Usually you get the cuff down after a day, no much bleeding, and then you can change it with another cannulated tracheostomy tube, as our ENT colleagues know. We can talk about a tracheostomy in another lecture, how to deal with it and how you manage it, okay? Different scenarios is we have a 37, and so this is the algorithm in your of the airway management in your mindset. Let's talk about scenarios and how we will manage it. 37-year-old, fever, drooling, and mild stridor. In an adult having a fever, drooling, he cannot swallow, and have a mild stridor, and it's a 37, I would think about, and it's an acute infection because there is a fever, thinking about a supraglottitis, it could be a diagnosis. So assessment here, history and examinations, the patient will have a mild stridor, should be compensated. Oxygen saturation should be fine. However, there might be some sort of distress, and you should, in that case, examine the patient, and the flexible knees endoscopy will get you that picture, which means that the epiglottis is edematous and see really edematous, and that's a supraglottitis. How you will manage it? So we start by temporary measures, as I mentioned, oxygen, nebulized adrenaline, and steroids. Some patients will be improved, and after that, they've been transferred to an ITU or an HDU or an experienced ENT ward to manage the airway deterioration or make sensitive to an airway deterioration, and that being closely observed. Most of them will get improved without any more, but some of them will really not giving, like these patients really edematous and it's be late, so it might be difficult. So we need an airway, and that would be the conversation with the anesthetist if I have a good one, and or an ITU. We need to secure the airway. Anesthetist will considering gas ventilation or awake fiber optic for this. Awake fiber optic intubation could be an option. Or if it's really edematous and distorted airway, then the other option, if, as I mentioned, gas ventilation or a ketamine and video laryngoscopy as an option to get in with a bougie to get an airway. If we really struggle, the third attempt will be used by video or a view scope or a laryngoscope. And if not, then you can go ahead and do a trach or an emergency airway, actually, which is an cricothyroidotomy. Scenario 2, we have a 43-year-old gentleman being presented with neck swelling, trismus, and significant stridor. So whenever there is a neck swelling and trismus, think about a deep neck infection, especially if there is a history of a teeth problem that has not been managed properly. Significant stridor here could be attributed to either compression, if there is a parapharyngeal component of the abscess, compression of the pharynx, it could be a stertor, but to be a real stridor, or it could be a Ludwig's angina pushing the tongue back, that can lead to a stertor rather than a stridor. These patients have a Ludwig's angina, bilateral submandibular cellulitis, really struggling with the airway. Those are patients they will need to, most of them will need to an emergency airway management. Some of them have the time to start to get improved with an mobilized adrenaline and the steroids, and you can start them on antibiotics according to the hospital protocol, get a CT scan done. And again, that will be a conversation with the anesthetist. We need to drain that, even if it's not so much abscess, because it's a compartment syndrome. The cellulitis here is compressed between the deep layer of investing, the deep investing layer of deep cervical fascia and the floor of mouth with the mylohyoid muscle and pushing the tongue back. So it will never go away by itself. It needs to be drained. So it means that it has to be done under general anesthesia. So again, the airway, even if the patient somehow improved, will need to be sorted in the theater, even when we drain it. Options here are you go ahead and flexiscope the patient and talk with the anesthetist. Again, no paralysis, mild sedation, or a dissociative anesthesia with a ketamine or an inhalational anesthesia. Here, video laryngoscopy is not preferred, and it has a reason for it. The tongue is already elevated. So the tongue is already elevated and it has a trismus, then whenever you compress the tongue, it wouldn't go away. So here, awake fiber optic intubation, stay away from pressuring on the tongue. Most of the anesthetic people will think like that, will go ahead with the CMAC or a laryngoscopy and try to sort it out. They will struggle. And I don't even recommend an interior commissural scope or a view scope, except if we really struggle as a last attempt. Awake fiber optic intubation here is a very good way of doing it. Sometimes you can insert a laryngeal mask. It wouldn't help much until airway, until like the ideal or the safest option here is to do a cricothyroidotomy or even a tracheostomy. because this patient wouldn't go away. It needs a few days to be, even with, if it's spreading like that, then cricothyroidotomy even might be better before doing a tracheostomy, okay? Because all the next spaces will be affected. So if we're lucky to get the patient airway with an ET tube, that will be ideal to avoid any communication with the tracheostomy or a cricothyroidotomy site in the neck to get the neck incision done and be drained. However, if not, then front of neck access should be a very expectable option. So here we have the conversation. Okay, you go ahead and start your intubation trial. Keep the patient ventilated. We don't like to have the airway as a the patient as a non-ventilatable or a non-baggable. Um, we could talking about our anesthetic colleagues usually saying if the patient has been ventilated or not. If the patient does not have a is it still compensated or not? We don't like to reach to the point of decompensation. Okay, to be non-ventilatable. That's a crucial key point. And because of that, you get your trials with a wake fibrotic intubation. And if not, then front of neck access could be on board and could be prepared for it. And this patient, if you get intubated, will need a drainage and will need to stay in ICU for 2 to 3 days until the swelling is really down, and then you can extubate him safely. We have another scenario with a 38-year-old lady who presented to the emergency department with a biphasic stridor, and oxygen saturation is now somehow desaturated, 89. History of ICU admission is a key, so it means that it's been intubated before and ventilated because of the COPD. Suspected from the history she had a laryngotracheal stenosis. And again, you will assess the patient with flexible, do the same thing, oral oropharyngeal, start with the temporary measures, oxygen nebulized adrenaline and steroids. Some of them are get really improved. Flexible knees endoscopy or assessment of the airway using whatever you have and neck as well. You cannot find a lot of information actually because maybe the stenosis subglottic, you cannot see it from the flexiscope, but you suspect it. And or even from the laryngoscope, the visual laryngoscope, 70 or 90 degree, but you suspect a stenosis. If patient is improved, you can investigate further with a CT neck and chest with some reconstruction to see the airway with a sagittal view to see how much stenosis it. It will need to be examined under general anesthesia anyway, if it's not an emergency on an elective basis, and we need to sort out the airway at that point. So again, this patient is, whenever you think about an intubating, start with an oral airway, laryngeal mask, get some oxygen, and then prepare yourself. Options here are video laryngoscopy and or a normal laryngoscope, but you have to choose a really tiny, smaller ET tube. If it's not working, then get a laryngeal mask airway to get some oxygen, and you have your ENT surgeon and head and neck surgeon on board. Options here are for railroad a tube on a small ET tube on a rigid scope, because the rigid scope diameter is a 4 mils. If you have a tube on top, so it will be like around a centimeter, which usually feasible or more feasible for any stenosis, and try to dilate it maybe first if you can. Put a tube in if it's really desaturated, and if a small tube in, and I don't like to use a bougie here. And we have some colleagues that use the bougie with an empty tube and it end up with a perforation as a trachea. So in this case, wherever there is a stenosis, I prefer either to go with a small ET tube without a bougie. If it's not going, then preferably hand it over to an ENT colleague to use it to do it under vision with a rigid scope. Hopkins rod, Hopkins rod, railroad the tube on top to see it under vision, or use a laryngeal mask ET tube, laryngeal mask airway, and then the ENT surgeon, he can dilate it with a balloon serially or putting some laser. Meanwhile, you maintain oxygenation and then secure the airway with a tube railroad on the Hopkins rod, and then do again another dilation with the balloon until the airway is really decent, then he can be extubated safely. Okay? And how we can put an ET tube railroad, you need at that point to hand over to an ENT doctor or a surgeon, remove his laryngeal mask airway, put the Lindholm laryngoscope in, see the vocal cords, put the Hopkins rod with the tube in, examine the airway, take it out, examine the airway with the Hopkins rod, try to put a balloon dilation, one or two, and then every time you go in and out, whenever the saturation is less, you still have the tube to railroad it quickly on your Hopkins rod. You use it for visualization. So that's from my point, the ideal way to do it. Avoid blind intubation in stenosis patient and try to avoid tracheostomy if you can, because it could be an option, because it can destroy your reconstructive options in the future. If you're thinking about resection anastomosis, you might end up with a laryngotracheoplasty with a stenting or something, because it's a long segment, because you have to take the tracheostomy segment with also the stenotic segment. So I don't prefer personally to get these people to be trached, except if it's a real emergency. So that's an airway stenosis, it's a grade 2 to 3, and or a grade 2 actually, and then needs to be dilated, as I mentioned. Scenario 4, 66-year-old gentleman, heavy smoker, presented with an emergency to the emergency department with a moderate stridor, change in voice, significant weight loss. That's what we talked about in terms of the history. I suspect a cancer process in the upper ear digestive tract, which is a laryngeal cancer mostly, or a hypopharyngeal cancer. Again, assessment, you start by temporary measures, oxygen, mobilized adrenaline, steroids, have a history, examine the patient, look for an airway assessment with a flexiscope or a laryngoscope. And that's what we can see here. You have a huge fungating mass involving it's actually an intraoperative view, but let's suppose it's a flexiscope view that should be upside down. The retinoid should be on top. The retinoid should be on top here, but suppose it is a flexiscope picture. So you have a fungating mass prolapsing onto the right vocal cord. So how you will manage this? Usually patient will get some improvement with the temporary measures. You can have some time to get a CT scan for the neck and chest. If it's really distressing or not showing good improvement after admission, then you need an airway management. And for those options, a weak fibrotic tubation can be an option. However, if the mass is really bleeding or bigger, then try to avoid a flexiscope, because it can be easily distorted if the airway is really distorted. So video laryngoscopy could be a very good option here, and put a bougie and tube on top. Other options are anterior commissure scope or a view scope if it's a disposable, to get the airway straight away down there and go even like beyond the mass to get the airway with the anterior commissure or view scope with a bougie and put the tube in, or put a video laryngoscopy and put a bougie and the tube in, or the last option is the front of neck, a cricothyroidotomy or tracheostomy. I personally, again, in laryngeal cancer, don't prefer to do a trach for a patient except it's really an emergency. Why? Because that can destroy the patient chances for survival on the long term, because it can end up with a peristomal recurrence. The tumor can spill down in the tracheostomy and get to the trachea, especially if it's even very extensive with an extralaryngeal spread. Tracheostomy in those patients can end up with a late peristomal recurrence, early or a late peristomal recurrence, and we have seen these patients. And anesthetists will talk or argue about it, so how you will remove this. So we will usually debulk it with a microdebrider or a cold instrument with adrenaline, and those patients, even when they are intubated, they should be extubated easily, or we can keep them for a night, overnight stay in ITU and get them extubated. That's really better than to do a trach for them. Scenario 5, which I think our last scenario, is a 19-year-old guy with a history of neck trauma. So neck trauma, especially if it's not presented with the hard signs, which is an overplayed or a refractory shock, or active played or a refractory shock, or someone with evolving stroke, or a definite airway emergency with bubbling or extensive surgical emphysema or stridor, that's all something needs to be sorted straight away in the theater. And options here would be definitely looking for a quick, safe approach, which is a front of neck approach, like a cricothyroidotomy or a tracheostomy. Even tracheostomy is here better to avoid anything in the upper airway because you might have a cricotracheal separation, partial or a complete. So you try to avoid the intubation as much as you can to get not to get the proper morph. However, I'm talking about another scenario. There is no airway bubbling, there is no surgical emphysema, so no an emergency airway. However, the patient have a hematoma. It's not an active bleed. It needs to be sorted with an ET tube and go ahead and fix the bleed. Now we're talking about slowly developing hematoma. That's again something, an urgence needs to be managed because this hematoma can build up a pressure on the lateral pharyngeal wall and make the airway stertor or distorted and may cause an airway problem during anesthesia. Options again here are after stabilizing the patient, getting a CT angio, talking with the anesthetist. We need to do that quicker than possible, not now, but within an hour or two. Non-paralysis, awake fiber optic intubation, or video laryngoscopy, or whatever. You have an adjuvant tool because you might find an externally compressed airway, and that will not be an easy airway. And again, other options for you, like a view scope or anterior measure scope, rather than to go ahead and do a tracheostomy because you need to open the neck as well. Will it differ if it's a blunt of penetrating? Definitely, if it's penetrating, could be a hematoma. If it's a blunt, think about there might be an airway problem because the airway here is squeezed, the larynx and trachea between the trauma from outside and the vertebral column. So if there is a blunt trauma and emphysema and I prefer bubbling, I prefer at that point to go for a tracheostomy. If there is an extensive emphysema or air bubbling, and depends on the assessment, neck assessment, and airway assessment with a flexiscope. That could be an option. But if you think about definitive airway for those patients, definitely if it's a blunt trauma with an airway problem, awake tracheostomy is, or a local anesthetic tracheostomy is a very safer option rather than cricothyroidotomy or any other method to avoid the potentiality of having a cricotracheal separation. Penetrating trauma, think about a hematoma if it's happening, because the active bleed shouldn't have any problem with the airway, especially if the airway is not involved. But if it's a hematoma, it's something needs to be addressed and needs to be talking with the anesthetist. It wouldn't be a straightforward the airway. We have to be prepared with an adjuvant tool, and you have to be prepared and try to avoid tracheostomy if you can, because that's kind of a little bit making some difficulty when you're exploring the neck externally. Okay, that's an example for a penetrating trauma. And that's an example for, this patient have an extensive emphysema and is still stable, and that's a CT scan for this and has a cricotracheal separation. For this, as you see, we preferably to do a tracheostomy, as you see here's a tracheostomy, and then sort out the airway with whatever method. That's a cricotracheal repair. Thank you very much, and that's it. And welcome to receive any comments. Thank you.